The views and opinions expressed on this program are not those of Norfolk State University or WNSB FM. Thank you for listening.
It's Hampton Roads Voices on Hot 91.
May is Mental Health Awareness Month. Each year, millions of Americans face the reality of living with a mental illness. During May, many organizations raise awareness of mental health, and they help us fight stigma, provide support, and they educate the public and the policies that support people with mental illness and their families. Hi, everybody. I'm Benita Adams, and this week on Hampton Roads Voices, we'll talk about being mentally and emotionally healthy. We'll talk to mental health experts who can help us discuss this sometimes very sensitive topic. Are Black men less likely to discuss their mental and emotional health? What can we do to stay emotionally healthy? Next on Hampton Roads Voices on Hot 91.
It's Hampton Roads Voices on Hot 91.
Welcome back, everybody. I'm Benita Adams, and today on Hampton Roads Voices, we're going to talk about being mentally and emotionally healthy. May is Mental Health Awareness Month, and so many times, especially in the African American community, there's a stigma attached to that, but we want to educate you about mental health and mental illness, support those with mental health, and support our families. And we'll look at are Black men less likely to discuss their mental and emotional health? Is talking about mental health taboo in the Black community? And what can we do to stay emotionally healthy? Our number, we want to hear from you. Our number is 757-823-9110. Call in and answer some of those questions. Do you think as a Black man, are you less likely to discuss your mental and emotional health? As an African-American woman, what are your thoughts on that? 823-9110. May, Mental Health Awareness Month. So in studio, we have Dr. Sharon Alston. She's an assistant professor here at Norfolk State University, the Department of Social Work. Dr. Alston, thank you for being here today.
Thank you for having me.
Absolutely. And on the line, we have Dr. O'Shane Gatson. He's an assistant professor of Norfolk State University, also in the psychology department. Thank you for being here, sir.
Thank you for having me.
Yes. So I think this really is an important topic, not just because we talk about it and have more of an awareness of it in May, but because it is important for us as we live our lives, as we interact with the people that we love. Our mental health is so important. So, Dr. Alston, I'm just going to start with you. Tell us a little bit about yourself and what you do, please.
First, I would always like to say I'm a native New Yorker.
Oh.
Educated at Howard University.
Oh, my.
And, I'm a interdisciplinary research leader with the Robert Wood Johnson Foundation. And I'm also assistant professor of social work here at Norfolk State University, where I teach research. Primarily, I look at the impact of environmental factors on African-American youth who live in public housing.
Oh, that's going to be, I think, a connection with what we're going to talk about today.
Absolutely.
And Dr. Gatson, tell us a little bit about yourself, please, sir.
Hi, I'm Dr. Gatson, an assistant professor in the Department of Psychology here at Norfolk State University. By discipline, I am a clinical psychologist whose research focuses on the relationship between the development of masculinity and emotional intimacy with African-American adult men. And I also clinically practice and treat a wide range of different types of patients. And my focus clinically as well as research is the Black community. And I'm so happy to be here once again.
Wonderful. I appreciate both of you being here. And I think that your disciplines and what you're doing has such a bearing on what we're talking about, the environmental effects of Black kids in public housing, intimacy in Black men, and the Black community. All of that fits very well with what we're going to discuss today. So let's lay the foundation. Let's first discuss and tell me the difference. What is mental health and what is mental illness? Dr. Gatson, I'll start with you. Mental health and then mental illness.
That's a very good question, and I've been thinking a lot about this throughout my years in the field. And if you had asked me this question years ago, my answer to your question would have been more traditionally focused and based on a pure European epistemology or idea of mental health. Mm-hmm. But now when I think about mental health, I think about the ability to cope, the ability to know oneself, the ability to accept oneself to not be split off, but to be integrated, meaning the ability to take in every part of one's identity, have it reconcile and be able to function in a way that allows one to be engaged with oneself and others, to be present, to be joyful, to have hope, and of course to leave a mark in terms of their creativity, and to be useful to themselves, their family, and society. So when I think about mental health, I think about it in that very holistic way.
It's so interesting that you say holistic, because that's exactly what I just wrote down. I said holistic approach, and that's what it sounded like. Now, what made the shift? You said you at one point, had I asked you years ago, you would have said something on the European spectrum and so forth. What made the shift? Your thinking?
I think that my own racial identity development and my own spiritual and psychological wrestling in terms of my own development helped me to realize that many of the ways in which traditional theory around psychology and psychological functioning is very pathologically oriented or pathologically focused. In other words, it usually looks at the deficiency being within, intrapsychically located. And what I've come to understand is that there are a whole host of external variables that can have a tremendous impact on how people see themselves that have nothing to do with how they innately see themselves or who they innately are. For example, racism, discrimination, microaggressions, oppressive systems, et cetera, et cetera. And so to me, in order to think about mental health, particularly with Black and brown people, I also think it's important for us to integrate a very communal and collectivistic approach that is very innate to who we are as a people, which means that mental health is not just about how I feel about myself, but it is in conjunction around what the community feels. I am the community is me. And so I think that these types of experiences that I talked about personally, and really deconstructing and looking at these models and paradigms of psychological function and psychological theory often do not take into consideration culture and cultural differences, and really try to box us into a norm that is based on white participants or studies that are primarily done by white experts or white clinicians or researchers and on white participants.
I agree. Dr. Alston, how would you define mental health?
So in addition to what Dr. Gatson just described, I look at mental health as a state of well-being. And when we talk about a state of well-being, it's the individual's capacity to deal with stressful life events, things that we experience on a daily basis. We're able to engage, establish, and maintain healthy and personal relationships. We can deal with things unexpectedly in a way that is proportionate to the event. We also are able to engage with the legal system. We can engage in the educational system and the vocational system in a way that is responsive to the circumstance. When we talk about mental illness on the other side, it's the inability to do those things.
I was going to say that. It seems like that's reversed then.
Absolutely.
Okay.
We have a disproportionate reaction and response to everyday things. And so also when we talk about culture and this negative view of how African American are experiencing mental health is, we could be an emotional group of people. We view and deal with different circumstances in different ways. We don't traditionally may not go to the therapist. We may not traditionally go to the hospital. We seek religious support. We seek support from our families and friends. And some will view that as a negative way of addressing, or a denial, a sense of denial. But really, when we talk about mental health, it's really having a state of well-being, that ability to deal with stressful life events that is proportionate to the circumstance.
I love that, both definitions. And let me make sure I give out the number, 757-823-9110. We're talking about being mentally and emotionally healthy today. And as you heard, our guest, Dr. Sharon Alston, assistant professor here at Norfolk State Social Work Department, she's saying, I think it was so fascinating, to the state of well-being, being able to have to react well in stressful life experiences. So that number again is 757-823-9110. How do you involve yourself in terms of being emotionally and mentally healthy? How do you address stressful life experiences, and how do you live with that? 757-823-9110. So should I say, Dr. Alston, that what, or maybe the question should be, what happens sometimes? A person can be mentally healthy. They know how to appropriately deal with life stresses, but sometimes something goes awry, something breaks, something cracks. Mm-hmm. Why is that? Sometimes the circumstance is too stressful, absolutely, or they've never been in that situation, so they just don't know how to deal with it.
Yes, absolutely.
Mm-hmm.
Everything is, life is not something that we predict. So we get thrown curveballs every day, and certain things that we've never experienced before will bring up some emotions and some insecurities and some uncertainties about what that is and how we go about dealing with that.
Right.
And we have the ability to just stop and ask for support or ask for help. Oftentimes people think that they're the only person who's experienced in this stressful life event. And then being vulnerable allows or prevents them from being able to ask for help, because then it seems that it's a weakness, especially if you're in positions of power, if you have higher levels of education, if you have this status within your community. People look to you to be the rock.
Absolutely.
And if you are unable to deal with a stressful life event, then it is viewed as you may have a weakness, or you may not be fit to hold this position. And some people don't want to really be able to admit that.
They don't want to admit that. And then Dr. Gadsden, it's so interesting. Let's link some of what you said in your intro about that. Dr. Alston says something about vulnerability or in the positions of power, leadership, authority. And when you talk about the black community and intimacy with black men, do you find that there's a connection with that in terms of mental health, being mentally healthy for black men?
Yeah, I do. I think we've discussed this before, and I think it's important for us to understand the similar but very different socialization processes that black boys undergo that set them up from the beginning of their development to not tap into their capacity around knowing themselves deeply or having a full range of emotions or expressions of those emotions. I think also to add to what Dr. Alston was talking about in terms of mental illness, I think we have to also consider and understand how internal and external variables impact sense of self. And when I talk about internal variables, I'm talking about that intrapsychic or those cognitive variables that each of us have. So some of us are prone in terms of our personality set around certain ways of being or thinking. For example, some of us are more introverted than extroverted. Some of us have different types of ways of engaging ourselves that can certainly be impacted by the environment. If you're in a space, for example, if you are introverted by nature and you're in an environment that demands extroversion, that can have a whole host of negative implications on how you see yourself and the types of things that you do to keep the anxiety down around who you are versus the environment and the context that you're in. So I think that it's important for us to understand that those internal and cognitive variables are very important, as well as how the environment impacts the sense of self.
I think that's so important. Yeah. We're going to take a break, and we'll come back to that point on the other side. But again, we are talking about being mentally and emotionally healthy, and we're really looking so very much at the question that I just asked about black men and intimacy and positions of power and being vulnerable. How are you teaching your black boys, your boys and girls, but your black boys, about being emotionally healthy? The number 757-823-9110. This is Hot 91.
Is Hampton Roads Voices. Hot 91.
Welcome back, everybody. I'm Benita Adams, and today on Hampton Roads Voices, we're talking about being mentally and emotionally healthy. We want to hear from you. We're talking about it in terms of the black community and how we see mental health and mental illness in our black boys, in our black men. Our number is 757-823-9110. 757-823-9110. What are you doing to keep your children, especially your black boys, healthy? Give us a call, 757-823-9110. On the line, we have Dr. O'Shane Gatson, assistant professor at Norfolk State University, the psychology department, and Dr. Sharon Alston here in studio, assistant professor here at Norfolk State University, the Department of Social Work. And so we have laid the foundation of mental health, what it is, and we've really made a great connection, I think, of how it can affect us on many levels in terms of, I was thinking about this as I was preparing for the show, in terms of the hashtag living while black, just doing anything while we are just doing our lives where we live, work, play, and so forth. And our mental health really is associated with that very much. And so it is important. Now, do women and men, Dr. Alston, I'll ask you, do women and men approach mental health differently? Is there a difference in that?
So I really would like to first talk about what this means about approach.
Okay.
Right?
Mm-hmm.
So we have whether or not we seek services, we ask for services, we receive services.
Right.
And there's some differences in that. But I can say, in terms of men and women discussing mental health issues or mental illness, there is a distinction. I can say that probably this is one of the double standards that would probably be true, that there's a real distinction between men and women as it relates to discussing mental illness.
Okay.
Women, I can really speak more specifically about young girls. They will talk to you. They will say that they're not feeling well. You'll see some of the symptoms, the crying. You'll see the withdrawal. They will actually communicate to you and say that I don't feel good. They will tell you that I'm sad. Boys, on the other hand, will not do that. They're likely to act out in aggression. They're likely to get in trouble in schools, get in more fights at home, get in more fights in the community, have police contact. So they're not likely to verbalize, to say that I'm depressed,
right,
or that I'm sad, that something has hurt my feelings. Girls, on the other hand, will do that. And as boys and girls grow up to be men and women, there's likely to be some similarities in the way men and women discuss mental health and mental illness.
Then, Dr. Gatson, how would we know a young boy is sad or depressed or something has hurt his feelings? How would we know if it just comes out in aggression?
Yeah, I was just writing that down. What I was writing down is that not only are boys socialized not to vocalize a full range of emotions because to do so is a sign or would be a sign of weakness, but oftentimes they're not even believed when they do articulate issues, or people don't properly assess it correctly. So, for example, when you talk about aggression, right, most family members, parents, brothers and sisters, and definitely, unfortunately, many clinicians don't assess what is at the root of that aggression.
Okay.
And so they will call it aggression or maladaptive behavior or conduct disorder, and not really understand that underneath many of these maladaptive behaviors, if we want to use that term, is depression and anxiety and fear and shame and trauma that is unresolved. So I think it's very important first to be able to really have a culturally competent assessment to look beyond the symptoms and to really get at what the symptoms are sharing with us, what is at root to these symptoms. And so, yes, we'll see aggression, we'll see disconnection in the academic domain, where they're not be performing academically or not involved or not thinking that these things are important. Some young men may have changes in their sleeping patterns, in their nutritional patterns. They may lose their quest for activity. They become inactive, so they're not playing sports or doing something that may keep them active. They may be sleeping a lot or have a difficulty sleeping. Many boys that I treat and black men often ruminate. So they can't get certain scenes or certain things off of their mind, and they just continually ruminate. So these are some of the symptoms or some of the ways that we might observe that something is wrong in our black boys and men.
Let me give you the number. It's 757-823-9110. Have you seen any behavioral changes in your children or your boys, especially in some of the things that we're talking about, maybe acting out, sleeping too much, not sleeping enough? Give us a call because we're talking about being mentally and emotionally healthy. 757-823-9110. So, Dr. Alston, how do we draw those boys out then? If we say they may not tell us that they're sad or depressed or their feelings are hurt, and maybe it just comes out in aggression, but we understand that girls would say, I feel this way, I feel that way. How do we draw that out of the boys then?
That's a really good point to make because as boys, they have this image to uphold, and it really becomes hard for them to disclose that. Wow. And I think it's a real skilled therapist to engage the youth in at the right time, right? We can't force them to talk about things because then they'll just push them away. But I think it's important for school social workers, for clinicians, for pediatricians to be able to begin to have that conversation with the boys at the point of contact. But I think it starts from a very authentic place and demonstrating to the youth that you see that there's a problem. That they're not, a kid that just wants to fight. That there are some things that they want to try to communicate, and to help them to communicate that to them to you. It really starts with building a rapport, being very authentic and genuine, and demonstrating to the youth that you are really here to care for them, and that you see that you see their pain. You see that they're hurting, and let them know that they're, better than that.
Better than that. And is it important for a parent? And then Dr. Gaston, I'm going to come to you. Is it so important for a parent to be in contact with that teacher, with that administrator, to say, I'm not sure, something must be going on with my son or with my child because he's acting this way. Have you noticed that too? How important is that part?
It's extremely important.
You are just really in my head today.
Go ahead.
I just wrote this idea of reteaching parents. I think it's really important that before parents begin to try to advocate for their children, that they first go through their own deconstruction process or parenting process or teaching process. And what I mean by that is exploring their own tendencies around maybe their own belief systems around masculinity and what they've also internalized that might be keeping them from accurately assessing what's going on with their boys or getting their boys help. This idea of sort of like this internalized idea of patriarchy that we talk about. So I think we all have ingested these views around masculinity and boyhood, whether we're boys or girls or men and women, that we all have to sort of be healed from. So I think that that's the first process. And then after parents are healed and really have assessed their own self and begin to tap into the observing what their children are going through, is that they have to advocate for their children, for their black boys. And advocate, to me, includes really asking questions of clinicians and teachers around their cultural competency. What do you see when you see my son? How do you feel when you see my son in the class? What do you think is his potential? How do you see his potential? And really getting an idea of how practitioners as well as educators are viewing your son, because that will give you indication around how much they will invest in your sons or invest in your children. So I think we really do have to ask those hard questions and really get an idea of what we're dealing with when we talk about administrators and other clinicians.
I completely agree with that. I was reading an article not too long ago, and it was talking about, and it's a connection here, Dr. Alston, a connection of saying a woman can't teach her son to be a man. She can only support him in that. Is that true? Is that false?
Well, I would argue that a black woman, is going to be what she needs to be for her child, and under whatever those circumstances are. There are things that, of course, a man can only teach. A child can only, a boy can only learn from a man. But there are some things in terms of life lessons that women do exceptionally well with their children, their boy children, their male children. So I wouldn't say that she can't provide that support and that level of education and guidance. I would disagree with that. I think that, again, I'm a black woman, and I know what black women are capable of doing, and they will do what they need to do to support their child.
I love that you say that. Let me give the number 757-8239-110, 757-8239-110. I just asked the question, can a black woman teach a black boy how to be a man? Can she support him as a man would support him? Give us your thoughts on that. 757-8239-110. As I was driving over here, I'm going to mention this to both of you, Dr. Gadsden and Dr. Alston. When I was driving over here, I heard an interview from John Singleton, who just died at age 51, writer and director of Boys in the Hood, the movie. I think it was in the 90s. And he said that he was initially for many years raised by his mom. I think he was raised in South Central LA or something like that. And when he was younger, I think up until age 13, 14 or what have you, he was raised by his mom. But his parents had never married, but they had an agreement that if at any point he needed to leave his mom's home and go live with his father because there was something more his father could give him, or he needed something emotionally or in terms of masculinity or what have you from his father, he would do that. And so he went to live with his father at around age 13, 14. And that really did spark that question in terms of, mom, dad, male, female. Dr. Gadsden, what do you think about that?
I think this is a hugely complex issue.
I do too.
and maybe we can get it around to a little bit of it tonight. Look, I think I've been having these conversations and doing some writing about toxic parenting. And I think that both fathers and mothers can be toxic parents.
Right.
And so I think that it's important to really understand the psychological and emotional and spiritual framework and background that parents are parenting from. So, hello?
Mm-hmm.
Yes, I was hearing something.
Right,
else.
I'm hearing some feedback, but keep going. We'll work on it on this end. Our engineer is going to take care of that. You keep going.
Yes, so the support and the teaching, if it's coming from a mother who is alone, has to be coming from a place of healing. Oftentimes, if a mother is not healed or a dad is not healed, that they're going to spew and infect their children with that pain that they're parenting from. So I just think it's important to just frame the conversation and say that we have to make sure that however parents are parenting, that they're not parenting from jealousy, anger, resentment, and projecting that or displacing that onto their children. Because I happen to treat a lot of adults who are in therapy still working through dealing with that type of displacement that they've received as a result of one or both parents. So to your question, though, I think it's important for us to understand when we think about, we could talk about this in terms of gender, like, fluidity and all that stuff, but let's talk about it from a traditional perspective. There are certain things, obviously, about manhood or femininity that, for me as a man, that I cannot teach my daughter, my 4-year-old daughter. There are general things around trust and respect and mutuality and giving your best and all of those sort of general ideas of values that I certainly can give to Zuri. But there are certain things around what it means to walk and function and perform as a girl and as a woman, and the very intricate details and pieces of those fears and fantasies that I don't have access to because I don't have that subjective experience. And so I would say the same thing for mothers. Just because you can do something doesn't mean you should do it. And so I think it's important for us to also say that yes, there are lots of black women who are carrying both loads, so to speak. But it doesn't mean that there are not huge or subtle negative consequences that children may be carrying that you are not able to observe right now, but may come up for them as adults.
Dr. Gaston, I'm going to have you hold that thought for
Sorry.
just a moment. Dr. Austin, I know you want to jump in on that. Do we have a caller? No. Okay, we had a caller on the line. Go ahead and finish that thought, and then Dr. Austin, I want you to jump in with what he's saying. So even though she's able to carry the load or able to do that, it's not necessarily healthy, or I don't want to finish the sentence for you.
Yeah, we have enough psychological data and object relations data. What that really means is the ability to which a person is able to relate as an adult to another person, i.e. the ability to be close to another person, to be intimate with another person, is hugely dependent on their relationship with their parents and that relationship. So I think it's important that both that parents are giving that love and that nurturing. And I'm just saying that we have to be careful in terms of the space in which we are parenting from. That it is a misnomer, and I think it's a misnomer because people are feeling shamed and guilty and all other types of feelings for being in certain circumstances. But I think there are things that people can psychologically miss. They can pick it up as an adult or from other people like uncles and deacons, preachers, brothers, etc. But there is nothing like the connection that a child has with both parents. And they need that psychological and physiological relationship.
I do agree with that. Yeah. Now, we're going to go to a break, Dr. Austin. I'm going to ask you to comment on that when we get back. Again, our number is 757-823-9110. We're talking about the importance of being mentally and emotionally healthy, especially for our black men, especially for our black boys. Give us a call. Give us your thoughts. 757-823-9110. This is Hot 91.
Is Hampton Roads Voices. Hot 91.
If you're just joining us, welcome. I'm Benita Adams, and today on Hampton Roads Voices, we're having a wonderful discussion about being mentally and emotionally healthy, especially as it relates to our black boys, our children, and our black families. We want to hear from you. The number is 757-823-9110, 757-823-9110. Give us a call and tell us your perspective on that. On the line, we have with us to continue with Dr. O'Shane Gatson, assistant professor at Norfolk State University in the psychology department, and Dr. Sharon Alston here in the studio, assistant professor, Department of Social Work here, again, at Norfolk State University. Dr. Alston, I'm going to have you jump into this part of the conversation. We've been talking about men and women and as they raise their children and so forth. How do you see that? I asked the question originally, can a woman raise a boy and teach him how to be a man?
So, again, I want to reiterate that I'm a social science researcher.
Okay.
That researches adolescents in public housing.
Yes.
And as you was talking earlier about what the reality is. So we can have, would like for parents to be this cohabitating traditional man and wife in a home raising children. But we know what reality is, that there are many single women who are out there raising little boys. And that's the reality. And so why we would love to have a man in a home and a man in the household to provide that. What do we tell a woman to do? To go find someone else to provide that service. She's going to be able to have to step up and do what is important. We also talked a little bit about what parents can do in terms of talking to the school. So I think about this concept called the ecological context of a child, and that is the relationships, the quantity and quality of relationships that exist, that the child exists in. So that's the school system, the church system, the educational system, the healthcare system, and the parents. And where there's a goodness of fit, where parents are communicating effectively with the schools, with the healthcare settings, with the legal profession, that there's a goodness of fit, and that trickles down to the child, or the child has a better experience in doing it. The other thing I want to highlight is, in my personal research, we look at the impact of parents. And if you ask children, they will tell you who has been more effective or more impactful in their lives. And we've done research in New York City, about 200 kids in public housing, another 400 kids in Washington, D.C. And we look at the maternal and paternal monitoring and encouragement of youth.
Okay, good. Very good.
And youth, they express that what has been most impactful for them is their mother's encouragement, regardless of gender. And so I believe that there's a role for both men and women in raising their children. but the children speak. And in this particular sample, the youth disclosed that their parents' encouragement was most helpful for them. So it prevented them from engaging in delinquent behavior, from substance abuse, that they were more likely to go to school, that they will have higher aspirations, more self-restraint, more social responsibility. So I think, again, I agree that there's a role for a man in their child's life, but under circumstances where he's not present, that we must support parents who are raising single parents who are raising little boys.
And Dr. Gatson, you're saying and making the point, we're talking a little bit about this off air during our break, that if that father, I'll just say father in this case, is not there, that that role has to be filled by, or should be, I should say, should be filled or can be filled by someone else. The pastor, the spiritual leader, the deacon, the coach. Am I following what you're saying on that?
Yeah, I think we have to, again, understand psychological functioning. And when we talk about research, really think about what we're asking and what we're not asking,
okay,
which determines what types of responses that we get. So I think that having encouragement from a parent does not necessarily mean that the child has not impacted psychologically or emotionally by the absence of another parent. So those are not mutually exclusive, right? So we have to ask questions in our research that are specifically targeting what we are trying to get at. In other words, does not having one parent, it could be a mother or father, has that psychologically impacted you? Has that impacted your emotionality? Do you wish that you could have? And what is involved in that wish or in that fantasy? I often ask those types of questions during assessment with patients, particularly adolescent and children. So I think it's really important not to downplay the importance, the biological, physiological, and psychological and spiritual importance of having support by both biological parents. But as Dr. Olson has said, we live in a society where we know that is not what's happening for all sorts of reasons. And that does not mean that a single parent cannot be useful, that a single parent cannot be loving, right? Or that the child cannot get something from that particular parent that will be helpful in their development overall. But I think we still have to speak to the pieces of their identity that are not. And I think that we have a responsibility as practitioners and as community leaders to be more vocal and more explicit about that. And to your point, yes, that can come from pastors and mentors and preachers, et cetera, et cetera. But what I noticed in my own private practice and also in some of the developmental research over the years, you look at the longitudinal research around this, is that, patients come 50, 40, 30 years of age and are still mourning and talking about and having relational issues that can be directly tracked from the absence or as a result of the absence of one parent. And tremendous wounds that they're still holding. Successful people who had step-parents who came in or who had other mentors that came in and, filled in the gap. But there's still, for many people, still that emotional gap that needs to be healed. And that's all I'm saying. Yes, we can encourage, we can be the best parents that we can be, but there is something that each of us gives differently that has to be spoken to, respected, and when not available, I think it is our responsibility as parents to seek it out.
You just heard from Dr. O'Shane Gatson, assistant professor in the psychology department at Norfolk State University. On the line and in the studio, Dr. Sharon Alston, assistant professor, Department of Social Work here at Norfolk State University. Dr. Alston, go ahead and jump in.
So there's a saying that says the cure is worse than the disease, right? And so when we ask these questions to children about, do you miss your father? Do you wish your father was present? Do you wish that there was somebody, a male figure living in the home? So those are interesting questions, and those are questions that practitioners want to know, right? Those are questions that maybe a researcher wants to know. but are there really questions that we need to impose on a child at this particular time? Does that further traumatize them? Does it further open wounds that may not even be present at the particular time? That might not even be something on the radar that the youth are experiencing. And then as researchers and as practitioners, we begin to ask these questions, and then we see the problems or the trouble begins. It doesn't say, I'm not saying that there is some challenges there, but sometimes the cure is worse than the disease.
So should we not ask the question?
Can I jump in? I think
Go ahead, Dr.
what is not dealt with and what is hidden will always creep itself up. And so I think, obviously, a clinician who is trained is not going to impose these types of questions without some sort of evidence or some sort of information, collateral information from parents, administrators, or really hearing the story or the narrative of their patient, and in this case, the child or the adolescent. But I think that we do something in our community that gets also transposed, and even the way that we work professionally is what I call the silent code. And from my perspective, from a theoretical perception, analytical perception, I think it's really important for us not to hide out or to hide or to not discuss issues that we have enough data to understand has implications. Yes, it may not be the most salient thing for that child. That is correct. And if it's not the most salient thing for that child, I don't think we should keep harping on it. But I do think we do need to not build this fantasy and this facade. Sometimes parents build this fantasy and facade because they're ashamed and guilty, but really not do that and really head on look at the implications of what is needed so that we can develop holistic healing strategies to speak to the individual needs of the child. So, no, I agree with Dr. Alston. One should not bombard patients with a line of inquiry or questioning that is more about what the particular scientist or clinician wants to know. But I think a clinician that is culturally competent and that is spiritually competent is certainly asking questions and leading and helping the person on their journey to discover those things that are unconscious, that might not even be understood by that person. That's really a part of what parts of therapy is about, is helping people to bring to consciousness those things that we can see, that we can observe through their behavior, but they're not conscious of, and then allowing them to come to that consciousness and deciding what they wish to do with that. So yes, I agree. We don't need to traumatize children, but we do need to have culturally competent, nuanced assessments of what we're observing and be able to speak to those things when we find that they are issues.
I do find it interesting. We'll take a break and we'll continue this on the other side, but I do find it interesting. I have heard examples where people, even though they are much older, they do yearn for sometimes. I don't know if it's just curiosity or just the yearning or the space that needs to be filled or what have you, but they do yearn for that. You hear the narrative, you hear the stories of, oh, I never knew who my dad was, or I never knew who this person was, and so forth. Had a great stepdad, or bonus dad, but I just, didn't have my biological dad there. So sometimes I have heard that story, and it is important to add that to this discussion. So I'll give the number at 757-823-9110. Give us your thoughts on raising black boys and being an African American woman raising them, and our emotional and our emotional and mental health. 757-823-9110. This is Hot 91.
Is Hampton Roads Voices. Hot 91.
Welcome back, everybody. I'm Benita Adams, and today on Hampton Roads Voices, we're having a great conversation talking about being mentally and emotionally healthy. May is Mental Health Awareness Month, and it's very important that we look at that, especially in the African American community, to educate the public, to talk about mental illness and mental health, and support those families and those people involved with that. We have two great guests today on the line. We have Dr. O'Shane Gatson, Assistant Professor in Norfolk State University Psychology Department, and Dr. Sharon Alston, Assistant Professor, Department of Social Work at Norfolk State University. And we'd love to hear from you as well. 757-823-9110. 757-823-9110. how do you think in terms of a black boy or a black child, a black teenager, how his or her environment affects his or her mental state, thinking the important role that a black father plays in his or her life? 757-823-9110. Dr. Gadsden, I'm going to start with you and ask you something that you mentioned before to make sure that my listeners really understand. You're talking about, I had originally asked the question about how important it is for a parent to talk to that teacher, that administrator, and ask him or her about and you're mentioning about being an advocate for your child, but you mentioned the term cultural competency, being culturally competent. Explain that a little bit for my listeners, and how important is that? Then, Dr. Austin, I'm going to have you jump in on this one.
Yeah, it's very important. When we think about culture, we're talking about a person's beliefs, their norms, their values, their language, and these things, of course, play a key role in every aspect of our lives. So cultural competence, from my perspective, is the ability of the practitioner to recognize and understand the role that particular person's culture plays in the treatment and in their ability to adapt to their needs. But when we talk about culture, we're not just talking about the culture of the patient or the client, but also the culture of the clinician, because the clinician is bringing his or her own value set and biases and ways of understanding and their social location and their own multiple identities, and that those beliefs that stem from those identities and into how they perceive the capacity of that patient, how they perceive the problem or the issue of that patient. So I think we really do need to continue to train and have conversation about whether or not there's a good fit when we have clinicians who don't have a deep or nuance or an openness to understanding the client's world. And when we talk about the client's world, how their race or their ethnicity or their gender is impacting that client's world or how that client sees himself. And so for example, we have a lot of research that says that black women are often diagnosed with schizophrenia when exhibiting the same symptoms that white women exhibit, and those white women are often diagnosed with mood disorders. So, there's a huge discrepancy in how clinicians often see the same symptoms and behaviors in black women, and will give black women schizophrenia is a psychotic disorder. It has huge, stigma. The medication is the medication is stronger, et cetera, versus someone who has a mood disorder, less stigma, et cetera. So that's one example of how that sort of gets out.
But Dr. Gadsden, you're not saying, are you, that unless I'm black or brown, I cannot identify as a clinician with a black or brown client? Can I be of another race or culture and understand the factors that are involved in this person's life and still affect them in a very positive way?
Yes. So I'm saying yes and no. So and this is another complex issue. Teaching in a PhD program for many years, I've trained black and white students, right? And what we're saying about this is that, and the research bears this out in terms of cultural diversity in the clinical context, is that often people are coming to their clinical work with their biases. And if we believe in white privilege and this idea of whiteness that can pervade how white people see black people, then we know that these biases are very entrenched and do impact how they understand black and brown patients and their comfortability around black and brown patients. And so what I'm suggesting is that clinicians who are not black and brown, as well as clinicians who are black and brown, need to invest and be a part of programs that help them to examine and self-reflect on those biases and to resolve in some way those biases and become open to resolving those biases in ways that help them to appreciate the culture and appreciate the types of patients that they are treating in ways that are equitable, that are fair, and that are responsive to the different types of patients that they're seeing. So yes, there are different types of clinicians, and they are are able to see different types of patients. But we do have enough research that says that often non-black and brown clinicians make lots of mistakes based on their biases and their privileges, that sometimes this enables them from being engaged and understanding the culture of their black and brown patients unless they are involved in this continual self-reflexivity.
I'm going to let Dr. Alston jump in. Dr. Alston, what do you think?
So one of the one key word that Dr. Gatson has mentioned that resonates well with me when we talk about cultural competence is this concept of appreciation.
Okay.
Because we can check the boxes when white therapists or other racial background therapists that work with African American people, they can check the boxes. We know that they're fairly oriented. We know that they love they love community, that all of the things that we can talk about the traditions of African American people. But that's just checking the boxes. It shows up when you really demonstrate an appreciation of those values, appreciation of those traditions. And we do that by engaging the client or the consumer in the therapeutic process. What has worked for you in the past? What some of the things that did not work for you?
Right.
You know, who are the people in your life that you would like to have engaged in this therapeutic process with you besides me? And I think, you know, all of the things that we say, and again, I'm talking about from a researcher's perspective. I know the cultural competence language, and I know that we need to be thoughtful and mindful and make sure that we are self-aware of our own biases, but it really doesn't do anything unless we really demonstrate a real appreciation for that client person, and recognize the dignity and the worth of the individual, and that we're doing this in a way that is productive and not harmful, that doesn't continue to subjugate our clients.
Let me go to the phones. Hold that thought for just a second. We have a caller on the line. Caller, what is your name, please, and where are you calling from? And can you turn your radio down?
I'm sorry, I didn't hear you.
Can you turn your radio down just a little bit? We're getting a lot of feedback. Okay.
Okay.
All right. What is your name, please, and where are you calling from?
My name is Jonna, and I'm calling from Norfolk. I'm a Norfolk State student.
Okay. Jonna, what is your question or comment?
My comment is that I do believe that a single parent is able to raise African American man. It's just like he said about having maybe like somebody who is spiritual to guide, to serve as a guide still in some sort of way. I think that's the necessity.
So you're saying you think that an African American female can raise a African American male child? You're saying?
Yes. I feel like she's able to do it because my boyfriend is a great example. His mom, she was a single mom, and she did a good job raising him. In my opinion, I came from a 2-parent household, so I do have certain expectations when I'm dealing with a male. Just because of the example that my father has set for me, and I feel like he's matching up very well to what it should look like, or what I feel like it should look like. And the stuff that he doesn't know or he doesn't understand, he'll say, "Hey, I've never seen that before," or I don't get that. My mom nobody treated her that way, or nobody, did that stuff for her because she was a single parent. But he also was in football, so that kind of, I guess, made it easier, too, because you have male coaches who kind of help guide you. So I think that's where that whole, having a spiritual leader or some type of guidance come in.
Somebody fill in that gap. Thank you so much for calling. We appreciate that.
Thank you. Bye-bye.
Okay. So Dr. Gatson, Joanna is saying that, really echoing very much of what you had said earlier in terms of it's possible, but again, there are these gaps perhaps that need to be filled in.
Yeah, I wrote an article many years ago about that gap in my own life, and really talked about some of the things that I had to learn on my own or by watching other males in my life who I didn't have access to on a consistent basis. And, how sometimes I felt behind the ball from what friends who had 2 parents or who had consistent male energy in their lives. And so I think that, again, as Dr. Alston is saying, that there are many outliers, that everything is not as salient for one person versus the other person, and that we have to take an individual approach to understanding the importance of phenomenon or the importance of topics to that particular person. But I do again think that that there is something very powerful about having the energy, the consistent energy, masculine and female energy in one's life, and having that modeled and seeing that modeled in healthy ways. And I just wanted to also piggyback on something Dr. Alston was saying about cultural competency, about appreciation and engaging the patient and really being able to engage the patient. And, I teach a course on the master's and doctoral level and been doing it for many years, cross-cultural counseling. And I have them journal every week, and they journal about their impressions, about what we're talking about, the topic, their own struggles in their clinical work. And my experiences have been diverse students, so mainly white, actually. And often these students are talking about their fears, their discomfort, and their own issues. And so I think you can't engage something or people who you don't understand, who you don't trust, who you don't feel comfortable with, who you fear. And so I think it's really important, and that is across race. It's not just white clinicians. It's even, as Dr. Alston was talking about, there are black and brown clinicians who don't get it or who are trying to project respectability politics onto their patients. But I think it's really important that clinicians really do self-reflexivity. And we do have enough, I think, psychological theory at least and research that says that when clinicians do their work around reflexivity and around working through and healing their own cultural biases and narratives, that enables them to be engaged in another way, in a deeper way with their patients. But you can't engage what you're afraid of. And we have to really deal with that with our clinicians and our practitioners, getting them to really unearth that, own it, and to work through it on a consistent basis.
But Dr. Alston, it seems to me that when we were during the break, you were saying that just because you were making the point of maybe I'm a black or brown person, but I am from this socioeconomic level. I have this education. I live in this neighborhood versus I live in this neighborhood, and maybe I don't have the cultural competence just because I'm a brown person.
Absolutely, there are so many differences within the African American community. We experience things from geographical locations, from north to south, or for family composition. For instance, I grew up in a family of 12. I'm the youngest of 12 children. My experience is going to be far more different than a person who grew up in a smaller family. I grew up in New York City. People tell me there's a distinct difference between my behavior and my attitude than it is when I come here down in the South. Those are just little nuances, but those are differences. And because I'm a behaviorist, if we have to identify who I am, and I'm a humanistic perspective. And so I have this ideology that, we can make the best of our worlds, right? Other folks may not have that same perception, which is really why I'm not in clinical practice, because I'll take all the kids home with me and take care of them myself. But there are extreme within differences that we have to be cognizant of and aware of. We are so focused on this racial differences between whites and blacks, and we don't even think about other ethnicities like the Latino community or the
Asian,
Caribbean, African Caribbean communities. We don't even think about those differences there, but we're really focused on between African Americans and Caucasians, and we have to look at some within differences because if I'm really going to be honest, sometimes it's those same ethnic groups that can do more harm or can do harm that we don't expect that to see. We don't expect we have some expectations when we go to other cultures that there may be a lack of understanding and some misdiagnosing of certain behaviors or being hypersensitive to some of the things.
Absolutely.
But there's not an expectation that we go to our black and brown therapists that we look for support and help. And sometimes it doesn't often happen that way. So we have to be mindful of the differences.
We have to be mindful. We're going to take a break, Dr. Gadsden. I want you to comment on that when we come back. And we'd love to hear from you, 757-823-9110. 757-823-9110. This is Hot 91.
Is Hampton Roads Voices on Hot 91.
I'm Benita Adams, and welcome back to Hampton Roads Voices. Today, our conversation is surrounded by and talking about being mentally and emotionally healthy. We have Dr. O'Shane Gadsden, assistant professor of NSU, the psychology department, on the line with us. And in studio, we have from the Department of Social Work at Norfolk State University, assistant professor Dr. Sharon Alston. We want to hear from you, 757-823-9110, 757-823-9110. Let's hear from you in terms of being mentally and emotionally healthy. Now, during the break, I'm going to start with you, Dr. Alston. I asked you the question in terms of PTSD, and I told you prior to my research for this show, I just assumed that was only for people who had been to war and they suffered from that. And you told me very clearly that is not the case. Explain that, because I find that very interesting and fascinating, and our guests need to know that.
So when you think about post-traumatic stress disorder, it's a response or reaction to a traumatic event, right? And after it has occurred. So after it has occurred, there are things that trigger you and that remind you in that, and it brings you to this traumatized place all over again. And so when we think about inner city communities, we can talk about violence, right? So we hear gunshots, we see those extreme fightings that happen, we see domestic violence that's happening. And so we think about community violence in terms of exposure, in terms of witnessing, and in terms of victims. And we also think about trauma in terms of secondary and vicarious trauma. And so all of these things can trigger traumatic experiences in youth or in individuals. And so it not necessarily you have been exposed to war.
Right.
We have things that happen every day. And we have things that happen in communities every single day that people witness that are very traumatizing, that are very, very traumatizing, and has an extreme negative impact on health and mental health.
I think that is so incredibly important to talk about, especially in the African American community. We think that depending on what kind of environment we live in, what type of community we live in, we think, oh, no, it doesn't look like that. But things that these young people, for example, in Chicago, when we hear about the shootings in Chicago and the death of young people and the killing of young people every day in Chicago, and that obviously is traumatic for them. And so you think about their mental health. What are they growing up seeing, hearing, experiencing there in Chicago or other communities as well? It's just the research that talks a lot about Chicago. And so we have to think about that in terms of being mentally and emotionally healthy on a daily basis for a young person like this.
And so what's also interested in the research is that although kids are witnessing this, it becomes so common that they don't identify it as a stressful life event. So again, some of the research we do is we ask some of the things, are there shootings in your community? Have you ever seen someone get shot? Or are there fighting in your household? Have you ever seen somebody get hit with a closed fist? And they say yes. And then you'll ask them, have you ever experienced a stressful life event? And they say no, right? And so knowing that these things are considered stressful life events, but they're so common in the community that they don't really acknowledge it as a stressful life event.
Interesting.
And some of it goes undetected. And then you see some of the behaviors we were talking about early on. And so depression that we were talking about earlier, if a black child, a boy is experiencing depression than a girl, and you see these behaviors, again, externalized out in the communities because they're not, and sometimes they're not really understanding where the problem is coming from.
Absolutely.
The underlying causes of why they're feeling the way they do and why they're jumpy and why they're upset or why they're irritated all the time. And so, again, PTSD is definitely not specific to war. I think that's where it comes from. If you ask kids sometimes what their experience is like, you'll hear things that's similar to that adults are experiencing in war zones.
Absolutely.
People are pulling out guns and shooting right there.
And that's that environmental factor, Dr. Gatson, that I think we had mentioned before. And you think about a child who, as you said, Dr. Alston, witnesses this. You see it. You've experienced this, even vicariously and so forth. How do you deal with that as a clinician? How would you approach something like that, Dr. Gatson?
Well, one of the things that we do with persons who are traumatized, and of course the trauma has to be identified by the patient, and of course trauma can be subtle or extreme in the ways that Dr. Alston just described, is to get them to really be able to talk about it. When we think about the trauma literature, at least around therapy, it's important for patients and clients to be able to have a safe space to, I don't want to use the word relive it, but to discuss it in some way, and to, in a safe space, to relive all of how that trauma has impacted them. So to be able to discuss honestly the various areas of their functioning that they feel like the trauma has impacted them in, to be able to discuss in a safe space all of the feelings around their power, their selfhood, their worth that has gotten impacted by the trauma, and then offering them an opportunity to really decide what they wish to do with that, to create a new narrative around how they understand that trauma, and really giving them the power to create narratives or new narratives that, of course, gives them the power to, or gives them the feeling of being empowered in ways that certain traumas steal power away from them. And then giving them, to your point of having exercises or really doing something with the work that they're in, having them take new risks around certain places that they may have not been comfortable in going to, being involved in certain activities that they may have not, that they no longer are involved with because of their feelings around the trauma, taking risks to slowly, from a cognitive behavioral perspective, to shift their schema around the reality of where they are now versus the trauma that they have experienced. But really giving them, in the beginning of the work, really the space and the time to really feel it, to really discuss it, and to not feel like they're wrong for how long it may take them to process it and to work through it.
Dr. Alston, go ahead and jump in.
So that's a really good point. And unfortunately that a lot of the kids return to these same communities. And so when you talk about the environment, if the environment hasn't changed for that child, they're likely to go back and be re-traumatized over again. And so, we can't take children out of their communities and place them in someplace else. And so a lot of work must be done within communities. So more community organizing around the importance of mental health and health for themselves.
Right.
All right. So because the urgency is not going to be for anybody else. Right. So in Black and brown communities, we have to realize that we have to take urgency for ourselves. We have to make mental health and safety for our children and our communities our priority, because other people are not going to be able to do that. And we can't, again, if you look at some other research, if you live in a particular zip code, your life expectancy will be much more. The kids that we talk about, the kids that we know about, particularly in Washington, D.C. and in New York City, they don't live in those zip codes. Those zip codes that their life expectancy is significantly less. And so if we're not taking, when I'm saying we, I mean we as African American people, if we don't see the urgency into changing the communities that we live in and to empowering ourselves to make better choices and have better options for ourselves, people are not going to see this as a priority.
Well, how do we change our mindset, Dr. Alston, or something like that, to make it a priority? I understand you're saying, yes, we should make it a priority, but how? How do we change the narrative, the story, the thinking, the importance of saying we've got to do something more, better, different?
So one of the things I know we're going to talk about at some point is about stigma. And so there is a stigma about living in inner city communities. And that's where we live. And that's what I'm a product of public housing, and I'm proud to say that. And so we have to take ownership and know that there is value and there is worth in those communities, and that we deserve to have better. We have to change our own narrative.
Okay.
And that starts with having I think having a better perception about who we are. And we're great people. We're a resilient group of people. And I don't even know if that's the issue, that we have to change the narrative. I don't doubt that there are people who live in Calvert Square, Tidewater Gardens, Grandy Village, who don't think that they have power, right? Who don't think that we need to make some changes. I think the problem is that we have to better organize. So that's what I would say.
Dr. Gasson, if you hold your thought, we're going to take a break and come right back with that. Our number is 757-823-9110. 757-823-9110. This is Hampton Roads Voices on Hot 91.
Is Hampton Roads Voices on Hot 91.
Welcome back, everybody. I'm Benita Adams, and today we're talking about being mentally and emotionally healthy with our guests, Dr. O'Shane Gatson and Dr. Sharon Alston. Now, before the break, Dr. Gatson, we had mentioned and talked a little bit about the safe spaces, the safe places where a person can talk about his or her trauma, talk about the issues, talk about those things. And yes, I know, of course, that a safe space would be with a therapist, would be with a clinician, but there are many, many people in the African American community who that's not how they're going to do it. They're not going to a therapist. They're not going to, one is there's stigma around that, or they don't believe in it, or they're in a community that says you don't need that, you need something else. So where are the safe spaces other than in a therapist's office?
Yeah, I think those are great points. I think that we have to continue in tandem to creating these new spaces or utilizing the spaces that we have to continue to destigmatize mental health and to help our people understand the differences between issues that require more mental health attention and assessment. So I think we need, in addition to that, more black and brown therapists who are giving therapy or able to give therapy at discounted rates. But I think you're right. While we're working on that, we still need to utilize spaces in which black and brown folks find themselves. And to me, this is still a great opportunity, and many black churches are doing this, where we need to partner more and collaborate with black churches. And we need to educate pastors and educate leaders in black churches who even themselves may not understand the differences between real mental health issues and something that could just be prayed about, and helping them to utilize or to integrate their faith beliefs with strong, competent mental health services and help and assistance. So I think we do need to build more collaboration with churches, more collaboration with social service organizations that are in our communities now, and continue to educate them as well. And some of this comes with grants, getting grant money so that we can provide these services for nothing to the community. Some of this is going to come from people who are going to do this pro bono. And again, utilizing the spaces that we do have, educating folks in those spaces like the church, community-based organizations, black-focused organizations, equipping them with the language and the understanding to be able to tease out the differences, and helping them to become open about using their privilege and using their power and using their podium to really start a new initiative in our communities around really face-on combating and talking about these complex issues.
Absolutely. And Dr. Alston, you had mentioned as well, one of the first steps or one primary step is really identifying that this is a mental health issue. How can, and we mentioned if a child is sad or depressed or something, any of the ways that we can identify that first, this is the problem, we are going to label it as such, and now we can figure out where the safe spaces are and what to do about it.
So I guess there's also some language about the use of this idea about problem.
Okay.
Right. So maybe it's a challenge, or maybe it's a limitation, or it's something that's impacting the family or impacting. And I think there needs to be a level of education about what distinguishes something from being normal responses to stressful life events. So a little girl a little boy who's crying because of a loss of a loved one or a cat or a dog, that's normal. Now, if they're crying for a year, that's something very different. So we have to be able to educate families to be able to distinguish between what is normal responses and what is not normal responses. Other thing is that we need to engage in more research. If you haven't noticed, I am a researcher.
Yes.
So we need to engage in more social science research and understanding the help-seeking behaviors of African American families. And so while they may not go to a therapist to ask for help, they may talk to a teacher, they may talk to a neighbor, they may talk to the janitor, they're talking to someone, and it may not be the therapist. And if we can really get to some real data on what are the help-seeking behaviors of African-American families, then we can utilize that information and we can capitalize on those responses and put resources there. So if we know that children are talking to their teachers because they feel a safe space, then we need to put some literature there. If we know that they're talking to pediatricians about what's happening, if parents are talking to their doctors, because we call I call it the medicalization of social welfare problems, they're likely to listen to the doctor because the doctor is life or death there. And so if that's where they're getting their resources, their information, then we need to put information there. And I know this to be true, that medical doctors are now incorporating these questions into their assessments about mental health.
Yes, absolutely.
Because they ask, have you feeling this? And patients are not really even acknowledging or realizing that that's what they're assessing for. So there's some things that is going on, but it's not initiated by the community. And I don't even know if the healthcare professionals are sharing this with the social service agencies or with their practitioners or with their patients. But I think from a researcher standpoint, that's what I'm looking at. I'm looking at the health-seeking behaviors of African American youth in public housing, and they'll tell you who do they go to. I'm not going to ask them if you feel like you're mentally ill, who you're going to go talk to.
Right.
But if you have a problem, if you needed to talk to someone, who would that be?
Who would
and they'll
that
tell
be?
you it's Miss Johnson downstairs on the 3rd floor, and it'll tell you that it's my arts and craft teacher because she gives me candy. They'll begin to share those experiences.
That's very important. Dr. Gadsden, I hear you want to jump on in with this.
Yeah, I just wanted to say it's, I think in addition to the collaboration with the Black Church, I think disciplines need to also do more collaboration because, and I would invite and share with Dr. Olson, the psychological community has been doing lots of research around these health-seeking behaviors with Black and brown folks. We call it cultural psychology or multicultural psychology, which has been really a blossoming subspecialty within the psychological community for probably over 80 years. So I think we do need to do more collaborations because the psychological community, although can be doing it much better, or much more nuanced, as all disciplines can, we do have a bevy of research, a bevy of outcome research and psychotherapy research and ecological research that we need to share more often with each other and collaborate with each other. So I think that's important to understand that we have researchers in all disciplines, and I think we need to talk more and have more type of conversations like this so that we can continue to do more integrative and multi-disciplinary work. The second thing that I wanted just to say is I'm of the thought as a researcher and a clinician that therapy is beneficial whether or not you have a quote-unquote strong or severe mental health issue. I want to normalize the sexiness or the efficacy and the importance and the utility of being able to sit still for 50 to 60 minutes a week or bi-weekly and have a safe space to talk, regardless of how extreme or how normal your issue or your concern or your challenge is. So I just want us to really think about the fact that therapy is not just for extreme issues or severe issues, but that there are spaces for you to talk about anything that is bothering you or anything that is troubling you, despite the degree of what problems or the degree angst that it might be causing you. Because I think that we still in our community think that this is something for people who are like schizophrenic or people who are, who have extreme bipolar issue, whatever the issue may be, or however we may dramatize it. But counseling, therapy, having a safe space is for anything.
For anything and anyone. I agree, and I just wanted, a thought came to me, and then we'll have to wrap up in about 4 minutes. But Dr. Alston, when you were talking about finding those places where people are talking, the lady on the third floor or my teacher, and I thought also simple things like barber and beauty shops. Men are there. They're there and they talk. And women are there and they talk. And if it's your hairstylist or your barber and you're sharing that information with them or your nail tech, those become safe spaces. They become places where you can share your thoughts and hearts. It depends on your relationship with them. But I just wanted to, as you were doing, Dr. Gatson, just take the mystery out of it sometimes, just knowing the practicality of it. So I'm going to ask each of you just some last thoughts and then some contact information. So Dr. Alston, I'll start with you. Any last thoughts for our listeners?
So I usually share this with everybody that I come in contact with, is that we should always lift as we climb, right? Because we're always in a different place, in a different space, and there's somebody else that might not be as fortunate as us. And that regardless of where you're going through or where you've been or where you are, your absolute best day, or your absolute worst day is probably better than somebody's best day. And so always to remember to lift as you climb.
Absolutely.
My email address is stalston@nsu.edu, and I can be reached there.
Okay. Anything on social media or just that particular number? Okay. All right. Very good. And Dr. Gatson, any last thoughts?
Well, I've really enjoyed this conversation. I think this conversation highlights for me, and I hope for our listeners, that there are a bevy of Black and brown researchers and clinicians who are thinking about the mental health of our community in very nuanced ways, and come to that conversation from different approaches, and that all of these approaches are needed, and all of these approaches can be helpful as we continue to disseminate and have these types of conversations in our community. And I just would lastly recommend and just say that seeing someone that looks like you does not guarantee that they hear you or understand you. But we do have enough research around this issue to know that it does put you on a different footing in many cases than seeing people who are not Black and brown. So I think we need, of course, Black and brown clinicians and white clinicians to be more culturally competent. But there is something around the history and the movement of Black and brown therapists who are committed to seeing our Black and brown community and patients in different and in loving and inviting ways. And so if you get an opportunity to see a Black and brown therapist, I'd ask that you give them an opportunity to help you on your journey.
Absolutely. In just about a minute to 30 seconds, Dr. Gatson, how can we find you?
You can find me at www.oshangadsdenphd.com. That is my website. And you can contact me if you're looking for someone to speak or whatever. You can contact me at ogadsden@gmail.com, ogadsden@gmail.com.
Thank you so much. That's Dr. O'Shane Gatson. That's Assistant Professor at NSU Psychology Department. Thank you so much, Dr. Gatson, for being with us today.
Thank you so much.
And in studio, we had Dr. Sharon Alston, Assistant Professor, Department of Social Work here at NSU. Dr. Alston, thank you so much for being here today.
Thank you for having me.
It's been wonderful having you here with us today. Remember, we're here every Friday, 5 to 7 p.m. If you need to contact me, my email address is bkadams@nsu.edu. Tell me what you want us to talk about. And we're online at Hot 91 Online. That's Instagram and Facebook. And if you want to hear this broadcast again, we rebroadcast this every Sunday from 12 to 2 p.m. Again, it's really been a pleasure talking to you today. Don't forget, every Friday and rebroadcast every Sunday. We are here for you to talk about the issues that affect our community with our guests and your thoughts. We're here for you. Thank you again. I'm Benita Adams, and we'll see you next week. The views and opinions expressed on this program are not those of Norfolk State University or WNSB FM. Thank you for listening.